this brief presentation on the peritoneal equilibration test. This brief presentation will cover the following aspects of the peritoneal equilibration test. We will discuss why we do the test, the sort of information that can be derived from the peritoneal equilibration test. We will also discuss how to do the test and some tips on how to do it more efficiently. We will also discuss the interpretation of the clinical aspects of the membrane function test, for example, how that might influence the prescription of peritoneal dialysis. And then we'll finish off by discussing the strengths and weaknesses of the peritoneal equilibration test. The main reason why we undertake regular membrane function tests on patients is that membrane functions differs considerably between individuals. And this is important because it affects the fluid removal characteristics of the peritoneal membrane. It has very little effect on the dialysis dose prescription, which is mostly determined by the total volume of dialysis prescribed. But the results of the peritoneal equilibration test do help the clinician to optimize the dialysis regime, and in particular to ensure that the desired amount of fluid is removed, and importantly avoiding issues such as excessive fluid reabsorption. It also helps to decide the optimal length of the dwell when you're using different PD modalities, for example, automated peritoneal dialysis. Importantly, the peritoneal equilibration test also provides a membrane-based definition of ultrafiltration failure, and this can be very useful when deciding whether or not to switch a patient from peritoneal dialysis to hemodialysis. There is also a substantial amount of evidence showing that the peritoneal equilibration test is a strong predictor of outcome for peritoneal dialysis patients. High solute transport in particular has been shown to predict worse patient survival, worse technique survival, and increased hospitalization rates. And I will show you the data to support this later on. We can also use the peritoneal equilibration test to monitor longitudinal changes in membrane function. This is important because it can be used to identify those individuals who've developed membrane injury or damage with time on treatment. And this is a risk factor both for technique failure and for encapsulating peritoneal sclerosis. Aspects of membrane function. It measures the solute transport characteristics of the membrane and the ultrafiltration capacity. Solute transport is the speed with which small solutes such as urea and creatinine pass across the peritoneal membrane. The faster they pass across, the more rapid the solute transport is. This in turn is determined by the number of peritoneal membrane capillaries in contact with the dialysis fluid. The ultrafiltration capacity, on the other hand, is a more complicated measure of membrane function as it is determined by several factors. It is the net ultrafiltration efficiency of the membrane, and that in turn is due to both the efficiency of the ultrafiltration as it is formed minus the amount of fluid reabsorption or disappearance from the peritoneal cavity. It is therefore a composite of several aspects of membrane function. For example, solute transport will determine to some extent the ultrafiltration capacity of the membrane. High transport patients will absorb glucose more rapidly, and this in turn means that they more rapidly lose their osmotic gradient. This is why patients with high solute transport tend to have less good ultrafiltration. In addition, Membrane efficiency varies considerably between individuals. This is something to do with the intrinsic characteristics of the membrane and is not fully understood, but is an important aspect of the determinant of the ultrafiltration capacity. Fluid reabsorption across the peritoneal membrane is also faster in some individuals, for example, high transport patients. It should also be remembered that the net amount of ultrafiltration will be determined by factors such as leakage of fluid from the peritoneal cavity. For example, this might be due to an inguinal hernia. And we must also remember that catheter function will vary quite a lot between individuals, and this will determine the amount of fluid that drains from the peritoneal cavity at the end of the peritoneal equilibration test. This slide shows the variation in membrane function observed at the start of peritoneal dialysis treatment. Both aspects of the peritoneal equilibration test are plotted on the same graph. On the x-axis you see the solute transport characteristics of the membrane, and on the y-axis the ultrafiltration capacity. Solute transport, which can be considered as the rate of diffusion of small solutes across the membrane, is determined by the endothelial small pore area in contact with the peritoneal dialysis fluid. On the y-axis, the ultrafiltration efficiency can be seen to vary considerably even when the rate of solute transport is the same. Therefore, these patients have different efficient membranes, and this in turn may be due to intrinsic aspects of the peritoneal membrane, for example, the expression of aquaporins, or the thickness of the peritoneal membrane, for example, due to progressive fibrosis occurring with time on treatment. It can also be seen that the amount of ultrafiltration capacity is lower in patients with high solute transport, and this is for the reasons already given. The patients with high solute transport lose their osmotic gradient earlier during the course of the peritoneal dialysis dwell. Can be then compared between patients and also longitudinally with time on treatment. The typical length of a peritoneal equilibration test is 4 hours. It can be undertaken at any time and anywhere, but it is important that it is never done after a dry period of dialysis. For example, in an APD patient who is undergoing a dry day. The reason for this is that there is absorption of fluid that remains within the peritoneal cavity at the end of an exchange, which will affect the amount of drainage from the subsequent peritoneal equilibration test. Typically, the peritoneal equilibration test is done with a 2-litre exchange, but this can be adapted to the normal fill volume that's done by the patient, and indeed that is what I usually do in our clinic. The ISPD recommends that the glucose concentration to be used during a standard peritoneal equilibration test is a hypertonic 3.86 or 4.25% glucose bag. It is noted, however, that many centres use a middle strength glucose exchange, either 2.25 or 2.5% glucose, and indeed in the literature there is more data with this value used than there is for the hypertonic exchange. In reality, that makes little difference. from a practical perspective, it has no effect on the measurement of the solute transport characteristics of the membrane, but of course a hypertonic exchange will result in a higher volume of ultrafiltration, typically around 400 mils more than you would obtain with a middle strength bag. In determining the solute transport rate, this can be measured at both baseline, 2 hours and 4 hours, but in fact, in reality, it is the 4-hour value that is of clinical value, and therefore it is possible to do a fast peritoneal equilibration test which only does a 4-hour estimate. It's important that you discuss with your laboratory how creatinine is measured in dialysis fluid. The glucose present in dialysis fluid does interfere with the assay of creatinine in some laboratories, and thus, to make a regular comparison between patients, it's important that this is understood and corrected for by your own laboratory. Finally, it is important to remember that the ultrafiltration capacity is the difference between the volume in and the drained volume at 4 hours. However, it should be remembered that CABD bags in particular are overfilled, often up to 200 mils, so this will affect the calculation of the final ultrafiltration volume and should be subtracted from that to get a true value. It's important to recognize that one must take both the whole patient view as well as the membrane view in making this definition. When considering the whole patient, then the important things to consider are the amount of ultrafiltration that's needed to maintain adequate or stable fluid balance. And this will be determined in turn by the amount of residual kidney function a patient has, the amount of fluid intake they have, how much glucose exposure is needed to obtain adequate ultrafiltration and fluid status, and then other factors which also affect fluid status in our patients, such as hyperalbuminemia and their subsequent overhydration of the tissues. However, the peritoneal equilibration test can be used in defining ultrafiltration failure from the membrane perspective. The current guidance of this is that when the ultrafiltration capacity of the peritoneal membrane is less than 400 mils on a standard peritoneal equilibration test using a hypertonic 3.86 exchange, then it is unlikely that a patient will be able to achieve good fluid management, especially when they're anuric. The same value for a middle strength glucose exchange would be less than 100 mils. And it's always important in these situations to exclude mechanical causes as to the poor ultrafiltration and also define the precise cause, for example, using other tests that are available.